Welcome to the Explainer. Today we're exploring one of the most high-stakes, honestly dramatic topics in all of cardiovascular medicine. We usually think of the heart as this purely mechanical pump, but before that muscle can squeeze, it relies on a delicate, highly coordinated electrical system. And when that system works perfectly, life goes on without us even noticing. But when it breaks down, well, the results can be immediate, terrifying, and life-threatening, often showing up as sudden cardiac events. So today, we're going to look closely at how these short circuits happen in the lower chambers of the heart, the ventricles. Okay, let's dive right into this. We're going to follow a very specific arc today, starting small and scaling up. 1. Premature ventricular contractions. 2. Ventricular tachycardia. 3. Ventricular fibrillation. 4. ECG diagnosis. And finally, 5. Initial management. Let's start with that first, basic electrical anomaly.
Section 1. Premature ventricular contractions, the single misfire. Don't let the long name intimidate you. This is simply where the electrical fault begins, and it's a great foundational starting point for us.
So a premature ventricular contraction, or PVC for short, is basically a solitary rogue signal. Normally, your heart's electrical impulse starts at the top and smoothly travels down to the ventricles. But in the case of a PVC, a single specialized cell down in those lower chambers just decides to fire off completely on its own, earlier than the next anticipated normal beat. Now, often, this single misfire is totally benign. A lot of us actually have them without even knowing it. But it's absolutely crucial we understand them, because this tiny, solitary misfire, it's the building block for much more dangerous, sustained rhythms. Now, here's a super fascinating clinical reality that shows why this matters when a doctor actually examines you. Sometimes a patient will have a PVC every single other beat. That's a pattern called Big Gemini. Because this rogue electrical signal happens so early, the heart literally hasn't had time to fill with blood yet, so it fires electrically, but it doesn't produce a strong mechanical pump. If you were taking this person's pulse at the wrist, you wouldn't feel those premature beats at all. You might count a heart rate of only 40 beats per minute, a falsely low pulse rate called pseudo-bradycardia, even though their heart is electrically firing 80 times a minute. It really goes to show how the electrical and mechanical systems can just completely decouple. Section 2. Ventricular tachycardia, the accelerating threat. So what exactly happens when those single, solitary misfires decide to team up? Well, we move from a mild anomaly to an escalating, accelerating threat. We defined ventricular tachycardia, or VT, as 3 or more of those consecutive PVCs right in a row. The heart is racing now, driven entirely by the lower chambers. And the clinical threat level here depends heavily on one strict rule, the 30-second rule. If the VT terminates on its own within 30 seconds, it's called non-sustained. But if it persists for more than 30 seconds, or if the patient becomes so unstable that a doctor actually has to step in and intervene, we call it sustained VT. And sustained VT is a massive threat. The heart is beating so fast it often can't pump enough blood to the brain, which leads to dizziness, passing out, or even worse. And this brilliantly illustrates the two main flavors of this dangerous rhythm. On one side, we have monomorphic VT. Mono meaning one, morphic meaning shape. Every heartbeat looks exactly the same on an ECG because the electrical signal is trapped running around a single fixed circuit, usually a patch of scar tissue. On the flip side, we have polymorphic VT. Poly meaning many. Here, the electrical shape is continually changing from beat to beat, shifting its axis wildly, kind of like the classic twisting pattern known as torsades de pointes. Polymorphic VT tells us the heart's activation sequence is constantly moving around, often because of acute issues like active ischemia or bad drug interactions. Now, understanding structural heart disease anchors a really vital concept. Monomorphic VT almost always occurs in patients with structural damage. Say a patient had a heart attack years ago. That damaged tissue doesn't heal like normal muscle. It turns into this dense, fibrotic scar. And that scar tissue forms a literal roadblock for the heart's electrical system. The signal just gets trapped, endlessly circling around the edges of that old scar, firing off rapid beats. That fixed anatomic loop is exactly why every beat looks absolutely identical on the monitor. Section 3. Ventricular fibrillation, total electrical chaos. We are now at the absolute climax of this escalating arc. If the heart's electrical system completely breaks down, we enter the most severe, life-threatening stage of all. Ventricular fibrillation, or VF, is literally total electrical chaos. There are no discrete heartbeats anymore, no recognizable complexes on the monitor at all.
Instead, multiple electrical waves are just crashing into each other simultaneously. The ventricles are just quivering, totally unable to pump a single drop of blood. This is a sudden cardiac arrest, most commonly triggered by acute cardiac ischemia, which is a sudden lack of blood flow to the heart muscle. This completely disorganized rhythm requires immediate life-saving defibrillation to shock the system back into order.
That is an intense escalation, right? From one dropped beat to total system failure. But it brings us to a fascinating question. If a patient is experiencing these dangerous rhythms, how do doctors actually figure out where the short circuit is hiding inside the dark, complex anatomy of a beating heart?
Section 4. ECG diagnosis. Playing detective with QRS morphology. This is where the science gets incredibly clever. We aren't flying blind here. By analyzing the shapes on a standard 12-lead ECG, physicians can actually play detective, mathematically tracing the danger right back to its precise origin. Now, what's truly fascinating about this is how beautifully form follows function. Because electrical signals take time to travel through the heart muscle, the initial site of the short circuit largely dictates the sequence of how the rest of the heart activates. The ECG is essentially taking electrical snapshots from different angles. So by looking at the resulting shape, we can effectively map the anatomy. The electrical shape tells us the physical location. It's like a giant puzzle. Here's the critical cheat sheet electrophysiologists actually use to recognize these patterns. Think of it like a grid. First, your horizontal rules. If the arrhythmia starts on the right side of the heart, the signal takes longer to reach the left side. That creates a very specific pattern in lead V1 called a left bundle branch block-like shape. Conversely, if it starts in the left ventricle, you get a right bundle branch block-like pattern. Simple enough, right? Now for the vertical rules. If the signal points downward on the tracing, an inferior axis, it means the short circuit started at the top of the heart and is traveling down. If it points up, it started at the bottom. By combining these vertical and horizontal clues, doctors can pinpoint the exact zone of the rogue tissue before they ever even look inside the patient.
Section 5. Initial management in defenses. Now that we know what these arrhythmias are and exactly how to locate them, we move to the most important part. How do we actually protect the patient and fix the problem? Let's move to the treatment steps and see how this builds from the least invasive to the absolute most advanced interventions. If a patient just has benign PVCs and an otherwise healthy heart, simple reassurance and maybe cutting out triggers like caffeine or alcohol might be all that's needed. If it's more severe, we might use antiarrhythmic drugs like amiodarone to suppress the bad signals. For recurrent dangerous circuits, we can actually go in and destroy the bad tissue with catheter ablation. And for folks at the highest risk of sudden death, we rely on the ultimate safeguard, the implantable cardioverter defibrillator, or ICD. For patients where medications just aren't enough, electrophysiologists can perform a catheter ablation. They thread these tiny specialized wires through the blood vessels right into the heart itself. Using those ECG clues we talked about earlier, they map out the exact electrical pathways on a 3D computer model. They hunt down that tiny patch of scar tissue or that rogue cluster of cells causing those misfires, and they use radiofrequency energy to neutralize it permanently. It's a real game changer.
So, the crucial point is right here. For patients with severely damaged hearts, we implant an ICD right under the skin. But notice the nuance. An ICD doesn't stop the electrical storm from starting in the first place. It simply watches, waits, and if the patient goes into ventricular tachycardia or fibrillation, it delivers a life-saving shock to reset the system. It's an absolute miracle of a safety net. It doesn't prevent the arrhythmia, but it reliably stops the patient from dying.
Which leaves us with a pretty profound thought to wrap up our explainer today. We have all this incredible technology to map the heart, and ICDs that act as a phenomenal safety net. But if an ICD only catches a patient when they fall, we really have to ask, what does the future of electrophysiology look like? What breakthroughs are waiting right around the corner that won't just shock the heart back to life, but will actually cure these complex electrical short circuits once and for all? Definitely something to think about as we continue to explore the incredible mysteries of the human heart.